è professore, ha un triplo ruolo che probabilmente non è così facile da conciliare, quindi gli faccio già i complimenti, nel senso che da un lato lavora come internista generalista, dall'altro è attivo per quanto riguarda la ricerca all'Università di Berna, quindi all'Istituto di Primary Care, e poi anche medico aggiunto al CHUV di Losanna, quindi tante cose. La strategia è quella di promuovere la medicina partecipativa, ne abbiamo già parlato anche dello screening, del significato, ed è di nuovo in questo tema che prende la parola Reto, quindi grazie mille per aver accettato l'invito di partecipare a questo meeting e grazie anche per spartire con noi la tua esperienza.
Thanks for the invitation. So, on m'a demandé de parler en français, mais pour garder l'unité, j'aurais préféré continuer en anglais. Est-ce que quelqu'un veut absolument que je parle en français? All right. Oh. Can we negotiate? So I think for the sake of having our international collaborators also understand what I'm saying, because I felt so many things, and I'm sure we didn't communicate before to coordinate our presentations, but I felt so much excellent elements that were said before. So if you invite a primary care physician, he will directly show you the pictures. We all have a colon, and these colon can produce or can have colon cancer develop in it. And so you have a normal wall, and then a polyp, and then a cancer. Not everybody gets cancer, and this process takes 10 years. So the good news, you can do something. You can remove this polyp, and then you don't get the cancer. You can do so with doing a colonoscopy, which you know is not something everybody wants to have, and you have to prepare yourself and then go to the gastroenterologist to remove these polyps if they are. And there's a risk associated of 2,000 of serious bleed. You need to stay in the hospital if this occurs. And then you have the FOBT, fecal occult blood testing, or FIT, immunological testing. And the principle is these polyps bleed a little bit. And so if you can detect the bleeding in your stool, then you can then go and do a colonoscopy. And so if you do so, you avoid doing directly a colonoscopy. And most of the case, 1 out of 10 only, you need to have, it's really a cancer if you have blood in your stool. Without screening, 2 out of 100 people will die from colon cancer before the age of 80 in Switzerland. With regular screening, 1 out of 100 will die from colon cancer before the age of 80 in Switzerland. I cannot know if you're gray, red, or blue. We can't know that now. So there's uncertainty. So you have 2 options, this fecal occult blood testing, this colonoscopy, or not doing anything. Fecal occult blood testing is every 2 years. Colonoscopy every 10 years. So you set if you do the colonoscopy, but the cost is high. It's about $800 in Switzerland to do that, minimal. Whereas the FIT test in only 50, depends if the insurance you have. We have very high deductibles in Switzerland, so that may make a difference. And you have these risks of 2 out of 1,000 with the colonoscopy of serious bleed. So what is your preference with regard to colorectal cancer screening? Who chooses, so taking here that you're over 50, you have no risk factors for colon cancer and no family history of colon cancer. So who decided not to screen? All right, so we have, I think, 2. Colonoscopy. All right. about 20. I think a lot of people will not decide. Indifferent between colonoscopy and fecal occult blood testing. Okay, about 3 or 4. And fecal occult blood testing. All right, it looks like same between colonoscopy and FOBT. Other method, because there are others. And I don't know. Good. So when I present this slide to the public health officials or public health scholars, I got one person who stood up and said, are you insane to propose colonoscopy as a choice for screening? And it was about 90% of people who said FIT is the option. And when I go to gastroenterologists, they will shout at me and say, how dare you offer FIT? Come on, I can do the colonoscopy and remove this. And between primary care physicians, there's a preference for colonoscopy. And when we ask in the overall population, or when I ask here, I see often this 50 and 50. And actually that work has been done by the decision aid I presented to you before, because this is a decision aid, and it has been sent in Geneva by colleagues. It's unpublished. It has been presented last year at this time. And they sent this to 4,500 inhabitants. 1,500 responded. And here's what they had. Colonoscopy and FOBT about half-half. And 84% relying on the primary care physician to discuss it. For internationals, the trust in physicians is the highest in the world in Switzerland. So variation in Switzerland. Yeah, that's what we found. Because we have this colon cancer program in Vaud where we propose this choice. And so we were faced with trying to train physicians to do so. So we would send people to go to primary care physicians to decide with them what they should do. And we had 24% saying, I only propose colonoscopy over the last 6 months, and 9% FIT and colonoscopy. And now we also did another survey where we asked physicians in Sentinella, which is a group of physicians in Switzerland who report for the influenza, but they can also collect data on for example, we use now colorectal cancer, and we see that the vast majority prefers colonoscopy compared to FIT. You have only 1 or 2 who only prescribe FIT, and you see nearly nobody in the middle who prescribe FOBT and colonoscopy. So there's variation between physicians, there's variation between cantons. Vaud now decided that FIT and colonoscopy is what you can do. And now you will have Valais and you have Jura who say, no, FOBT is the choice we will send, and most of the cantons are not doing something yet. And there's variation, I told you, between health professionals. Pharmacists prefer FIT. And variation by country, come on, this is crazy. So you have different countries in the world that take other decisions, and everybody stands behind that and says, I think we have the solution. It's FOBT at home. And in Germany, it's colonoscopy invitation. And this cannot be true. Because what's the problem? The problem, if we consider that we have 50-50 preference, and that's in Switzerland, that's in this room, that's in the USA, and that's in the Netherlands, where we have data on this. If I am somebody that prefers FIT, and I go to a physician and have a colonoscopy and have a serious bleed of it, what is this? Is this a medical error? That doesn't come in the journal. So if operating on a wrong leg is considered a medical error, how do you call operating on someone who doesn't need surgery? And that applies probably for colorectal cancer screening, so it is a preference-sensitive condition. And so the whole movement of shared decision-making has been done to solve this problem, the problem of variation in care. And now we need to find a way to fix this. And shared decision-making is one of the options. And I'll tell you all about other things also that we're trying to do. So what is it about? So as physicians, we've been trained to diagnose diseases, right? And you just rightly said, we need to diagnose preferences because we cannot solve this problem as a closed group in a room deciding with guidelines what people should do. We need to open this conversation. And we have spent a staggering amount of time and energy over the past several decades developing, discussing, and debating guidelines. Professional advocacy groups have spent much time aggressively advocating for the adoption of guidelines supported by the respective groups. It seems that it would be much more productive to devote this energy to educating screening candidates, the harms and benefits of screening, and engage of shared decision making. And I know here in the room, you all think we should work in this interprofessionally, and it's excessively important when we go and speak with the patients about the choice and the options they have. It costs $300,000 to do a guideline. It costs $300,000 to do a decision aid. And now think back in your group when you were in the guidelines, how much money was allocated to this problem, how to include patients in this decision and get also the resources for it. So the organized screening program in VO, target population is people aged 50 to 69. And that's a reason because that's what it's covered by the insurance now, 108,000 eligible. And it's a proportion of promotion of systematic informed choice on colorectal cancer screening. Have you seen this? The proportion of systematically informed choice. Do we want to increase the rate of screening? Do we want this? People sometimes don't want that. Do we want to build in incentives so that people do more screening? No. We want screening to be offered to everybody despite of financial incentives, that everybody is in a position to take a decision, not to convince everybody to do something. So this is critical, and it's at the core of this program, and we think it's unique in the world. So colonoscopy every 10 years and FIT every 2 years. And of course, you need to do a colonoscopy if the FIT test is positive, and that's the reason why you need an organized screening program so that you can follow these people. Because if you don't do that in an organized screening program and just distribute FIT tests, people don't come back because nobody wants to do these colonoscopies. And this is not okay. So once you decide to do a FIT, they need to go and understand before they do it that they need a colonoscopy afterwards. So it's to facilitate an informed choice for colorectal cancer screening, a systematic indication to discuss screening and type of screening with primary care physicians. Have you seen what's written here? With colon cancer screening, age 50 and over, I'll talk to my doctor about it. Is it discussed, go and get your screening? No, go and talk to your doctor. Reimbursement of screening colonoscopy of FIT by healthcare insurance is only since 2013, and we're so happy it is now. And payment of deductible now when you are in a program, colonoscopy of FIT test, and a consultation with the PCP, 15 to 30 minutes. Speaking of incentives, primary care physicians have no incentive to prescribe colonoscopy of FITs. That's the reason why this place now in Switzerland is an ideal place to do shared decision making, because you don't have financial incentives. Is it the primary care physicians? I don't know. But you need to find a room where the financial incentives are aligned. And you need time for it. And it's billed. And the primary care physicians get reimbursed 30 minutes shared decision making time, even if the patient refuses it. Think about it. What a nice healthcare system. I'm so proud. That's the reason why I came back from the USA, to come back to Switzerland, because we can build the time as we want. If I want to spend 45 minutes, I can in primary care. That's essential to build up the trust. I told you, number one, trust in Switzerland. Second, in inclusion of decision in the world, according to a Commonwealth report, behind the UK. So now you see we're worried. So I told you the preference of the physicians is to prefer colonoscopy. So now we're sending people there and saying you have the choice, but we know it will be hard for them to do that. So we were in charge of training and teaching physicians how to do so. So we developed these decision boards. And I believe a lot in these decision boards, because when you go at the core of it, this thing that you use in the primary care, then you get back and say, oh, wait, this paper, it's written here, I have the choice between the two. And the patient knows that. And then also the absolute risk is here. And these materials are simple to understand. And don't think physicians need complex things. They need simple things too. They are patients too. And they need very simple things too. So I think there is something about implementing just these 2 pages. And of course, epidemiological summaries where we collaborate internationally and we try to put as much evidence. Of course, the evidence Gerd Gigerenzer and the Harding Center group put in with these absolute frequencies, but also the work of other people in Michigan and the US and other randomized trials showing how you can not only make people understand risk, but also make informed decisions. So that's what we got when we did our outreach of 2 hours training. And our physicians, before we asked them, well, what did you do before? And that was the rate I told you, I showed you before. And then after the course, by showing them a story of a patient, what did they do? And you see that we could increase. So it was an intention. What do you intend to prescribe over the next 6 months to your patients? And we increased it to 36% of the physicians who intended to prescribe both equally FET and colonoscopy. That's still 74% who don't, right? So now we're in the next phase. And what we do, we are a group of primary care physicians, epidemiologists, ethicists, and also groups of patients, and most importantly, colleagues. And we developed these in a community-based participatory approach to say, how do we collect data and quality in our practice? And collecting quality about colorectal cancer screening is not my screening rate. Of course, it is how many have been screened before. But it's also, did I have the time to discuss it at that moment? And what did the patient decide? Did they decide not to do the test? And you can record this, and this is a positive outcome if you reached the point that your patient decided. And so we monitored, that's again, these data from Sentinel I told you before about the variation. We used this data collection sheet for the graph I showed you before. So 45% are already tested. We don't know if it's screening or diagnostic. That's way higher than any other country. That's often the case in Switzerland. We don't do a lot of big things, organized things, and the care gets done. So I don't think we're in a bad situation. We're in a bad situation because apparently the colonoscopy now is really the first choice. There's a variation in the percentage of patients who have screening. You have some physicians who have already 80% tested and others only 10% tested. And a variation, as you saw, in proportion of patients who got both options. So now we're trying to intervene on this. And so we are in a phase where we did the pilot intervention at quality circle. Quality circles of physicians, pay attention to this. Toyota revolutionized the industry of automotive by quality improvement. This was based on PDCA. PDCA is implemented in primary care in the 80s already in Switzerland. 80% of the physicians in primary care physicians in Switzerland participate in quality circles. So speak of quality improvement efforts, this is a tremendous effort. So we use this resource because we think physicians don't change by sending them just charts of what they did or pay for performance. We think they should own and lead quality improvement. And so we developed and tested intervention in a pilot quality circles, and they co-participate in how do we measure the outcomes, what do they need? And there are 9 primary care physicians, 3 meetings of 1.5 hours, and they now also collected data on 176 patients. What we see that they had rates of testing before that were 35%, so lower, and way more colonoscopies than FOBTs. And after that, after we discussed it, after they used these decision aids, after they included patients in the discussion, we suddenly found, and we were flabbergasted by this, that there was a huge increase in just the number who decided something, right? Some decided not to do it, but just discussing it, they could decide. And after it, we got these proportion of 41% and 32%. And how come did that happen? So first of all, I told you, we record the amount of time we could discuss it. And so here, a couple of people discussed it each time while they collected these data, and I said, no, I don't have the time for it. And so what was the decision after discussion of the amount of participants who had never had a screening or a testing and were eligible to discuss it, and the discussion was the, way 90% FOBT versus colonoscopy. One of those was a surgeon, ex-surgeon that was then primary care physician, and say, in my life, I will never prescribe a FIT. That was the first discussion. And once he discussed with a colleague that was only prescribing FIT, both together said, well, that's weird. So let's talk together. And he used this decision aid I presented to you before, the one before with his patients, and said that was crazy. Suddenly patients came in and said, yeah, I don't want this colonoscopy. I prefer just a FIT test. If it's okay, I prefer to have that one. So we don't know exactly what happened. So I know what happened, and that's really how professionals change. Highly independent professionals, that's the way they should be handled, is by respect. If we expect shared decision-making to happen and to be respectful for patients, the way we try to change our colleague has to use the same methods. And so one thing that could happen is now you have the choice of FOBT. I told you we're in a situation that's a randomized trial in San Francisco where colleagues only offered FOBTs and an only colonoscopy and then both. And what you see is a very large increase once you start offering a FIT test. And so the next phase is to do a cluster randomized trial where we randomize these 12 quality circles to get the intervention, and the other will get it 6 months later. And I think a lot, this wonderful grants program, NRP 74, to allow us to do so. So in conclusion, the future of screening program, well, I hope to get systematic choice instead of uninformed compliance. The quality metric is the proportion with decision, not the proportion screened. And you need to measure this, and you need to find the financial incentives for it. Spend reinforces on informing and involving invitees in decision, not in debating guidelines. And provide health professionals with decision aids to help them inform invitees and diagnose preferences. And healthcare providers are trusted. Consider healthcare providers are trusted advisors for health decisions.